In today's video, with the help of this real human knee, we're going to see how knee replacement surgeries are performed and what the patient can expect once it's all said and done. It's going to be an interesting one. Let's do this. Now, the proper name for a knee replacement surgery is a knee arthroplasty, and there are two different types of knee arthroplasties. You can have a partial or a total knee arthroplasty. And the names are probably pretty self-explanatory, but in a total knee arthroplasty, they're going to replace and resurface all of the articular surfaces of the knee joint. So that includes the femur, the tibia, which is going to be this bone here. You might actually be able to see it a bit better if I go like this. So the tibia, as well as, and I can reflect this back, the articular surface of the patella or your kneecap. Now, in a partial knee arthroplasty, they're just going to be doing less than a total. So maybe they're resurfacing one or more of the condyles of the femur. Now, in order to be eligible for a knee arthroplasty, it really comes down to your age as well as how much damage the knee has accumulated. In terms of age, they tried to just do people who are 60 or 65 or older, and that's because this is a really extensive surgery and the recovery is no joke. And the prosthesis really only lasts for a couple of decades, meaning that if you do it at age 30 or 40 or 50, you're gonna have to do it again, and that is a whole process in and of itself. But again, it depends on the surgical team and your specific circumstances. They can definitely do it when you're younger. In terms of damage, the damage typically comes from arthritis, and there are different types of arthritis. The first one I want to talk about is called osteoarthritis, and that is a wearing down of the articular cartilage. So if you look here at the femur, and you can see as I'm moving it around, this whole surface would be covered in what's known as hyaline cartilage, which is a very smooth and slippery type of cartilage that allows for just, nice joint movement. If that wears away, you'll get bone-on-bone contact and you can create this. So if you look here, you'll see this red, and I'll kind of move it around. You can see the shape is completely different. That is arthritis. Those are called osteophytes. They're basically bony outgrowths where the femur has grown outwards to try and push the tibia, that shin bone, away. It's literally your body is making things worse in an attempt for you to stop moving, right? You can think of it as the bone's just like shoving the other bone away and saying, let's not do any more movement and make this any worse. But another type of arthritis would be an inflammatory arthritis. So maybe you had gout, which is where you have like uric acid crystals forming inside of the joint, or maybe you have rheumatoid arthritis, which is where there's an inflammation, an autoimmune disease type of inflammation on the membranes that surround the joint. Or maybe you had some kind of traumatic knee injury and they just need to resurface or help reconstruct the knee. So all of those are going to be indications for a knee arthroplasty. Real quick, I want to thank the sponsor of today's video, Yoga Body Teachers College. When this lab first opened, we exclusively taught in-person events to a variety of different students. So you had medical assistants, dental assistants, EMTs, paramedics, massage therapists, and those going through yoga teaching certification programs. And I remember being very surprised with how much yoga teachers actually knew about the human body, which is one reason I'm even more impressed with Yoga Body Teachers College. They specialize in science-based online certification programs for yoga teachers, yoga breathing coaches, yoga trapeze teachers, and stretching coaches. If you're interested in starting a new career or maybe even just a new side job, helping people improve their health, overcome injuries, manage stress, or just live their best lives longer, Yoga Body's courses might be right for you. Check this out. Since 2007, they have certified over 23,000 teachers in 41 countries. That is ridiculously impressive. They're backed by Yoga Alliance, American Council on Exercise, and American Council on Education, making them one of the only schools in the entire world eligible for college credits. And they've put together a free report for you called How to Choose a Yoga Teacher Training Program. You can access it immediately at yogabody.com/IHA, or you can just click the link in the description below. All right, let's get back to it. So before the procedure can even happen, there needs to be some preoperative medical imaging. And this is so that the surgical team can properly plan for this surgery as well as determine the proper size for the prosthesis that'll be inserted into the knee. So I want you to think about this. Every single one of our bones, while they follow a plan, right? A femur is shaped like a femur, there's still going to be unique aspects to it that are determined by posture, weight, and all sorts of individual circumstances. So what they're gonna have to do is measure things, right? They'd measure the tibia, they'd measure the patella, they'd measure the femur in order to just have a properly fitting prosthesis. So they'll do an MRI, they might do a CT scan, it really just depends. Now, for the procedure itself, you're obviously gonna get an IV You're going to go underneath general anesthesia, so you're not awake for any of this. But from there, this is where they have the option to provide a tourniquet. So this is actually kind of controversial, and it depends on the specific surgical team and institution and whether they elect to do it. Because think about it, when you apply a tourniquet, right, you're stopping blood flow to this entire area. So first off, if you stop blood flow, what's nice about that is it makes for a cleaner area because the blood is not obstructing the view. However, this means there's going to be an increased chance of blood clots. Also, what they find is that the patients tend to experience more pain post-surgery, and that means they're going to have more medications, and that just comes with a whole slew of problems in and of itself. But again, with the tourniquet, since things are cleaner, what they're going to be able to do is build the surgery quicker, right? If you can see things more easily, they're going to do things quicker, so you have reduced surgical times. So, I mean, look, it kind of depends on the surgical team and what they want to do. They're now going to make their incision, and they're going to do what's called an anterior midline incision. So they're going to be making a longitudinal incision that's going to travel from above the patella, about 6 to 12 centimeters above the patella, over the patella, and then down towards this spot here, which is known as the tibial tuberosity. You can feel this, it's a little bump on your shin bone. But what they're going to do is they're actually going to make that cut when the knee is in a flexed position. And the reason they do that is because when the knee is flexed and you cut it, all the tissue can fall to either side. If the knee was in the extended or kind of straight position and they made that same cut, all the tissue would be bunched up and they'd have to pull it apart and it just wouldn't be as efficient. So they'll flex the knee like this. Hopefully that's coming across like this. Then they'll make that anterior midline incision, tissue falls to the side, revealing all of this here. So what you're looking at is part of the quadriceps tendon. So the patella is a bone that is actually suspended and immersed in a whole bunch of tendons because you have 4 quadricep muscles that are all going to be sending their individual tendons to this one location, which will then go down to the tibial tuberosity. So they'll be able to see the patella and they'll be able to see all of this. From here, this is where they're going to perform what's called the medial parapatellar incision, or at least the median parapatellar approach. And what that means is, like, think about this. There's a lot of tissue here. You're going to have to cut through it or go around it in some capacity. What they'll do is they'll make an incision that will go around the patella, and they're cutting into this aspect. So what would happen is there's a muscle that would be right here called the vastus medialis. And this is its contribution to the quadriceps tendon. So what they'll do is they'll cut that going around that patella, but leaving enough tissue that they can reattach this when the surgery is done. And when they've done that, they will then be able to grab the patella and slide it laterally. And as they slide it laterally, they're then going to flip it. Now, I can't actually flip it in the way that they do. Instead, I'm going to have to flip it like this. But you can still see exactly what they would see, right? This is what they're seeing, but instead, this whole aspect would just be reflected like so. And what that does is it exposes the articular surface of the patella, and then as they pull it aside and hold it with retractors, it gives them operation space. Now, at this point, they can start removing tissue. And so the things they're going to remove, I'll go ahead and reflect this open again, are going to be, say, the menisci. So if you look right here, I'll try this with my probe. There's kind of like these cartilaginous pads that are separating the femur from the tibia. Now, these cartilaginous pads are shock absorbent and they're there to cushion impact. Now, typically, if you're getting a knee replacement, these are probably damaged, if not almost gone outright, but they're still going to remove it because they're going to be replaced with a polyethylene plastic. They're also going to remove the ACL. So if you look inside of there, you might be able to see, I'll try with my probe. Right in there is the ACL, is what I'm directly palpating with the probe. But these are the cruciate ligaments. You have the ACL, you have the PCL. It stands for anterior and posterior cruciate ligaments. And they're crisscrossing in the dead center of the joint. And their goal is to actually prevent translation of the tibia in relation to the femur. So what I mean by that is, so we have the tibia here, we have the femur here. This isn't obviously going to work, but you can kind of picture if the ACL ruptured, the tibia would actually slide in front of the femur. That's what the ACL is going to prevent, while the PCL will prevent posterior translation, going backwards. So they're going to remove the ACL. They might remove the PCL. It kind of just depends. That also is controversial. Just understand that whatever you remove, you're going to have to then, give back in terms of the prosthesis or some kind of attachment to the prosthesis. So it just kind of depends on the surgical team and your specific circumstances. Now, once they've done this, they've removed these tissue. There's also some fat that they can remove in this area. This is where they're then going to actually start resurfacing the tissue. And if I haven't made this clear, I want to make it very clear right now. It's not as though they are like chopping off the end of the femur and then replacing the entire thing with titanium. What they're doing is they're resurfacing. They're going to actually cut away the arthritic or damaged components or portions of the knee, and then they're going to replace those with the metal alloy. So in order to do this, there's two different ways. You can do this manually. So the surgeon is doing this with their eyesight and expertise alone. Well, there's going to be some assistance, or robotic or technologically assisted. So if they're doing a manual one, what they're going to do is they're actually going to drill into, about right here, they're going to drill into the medullary cavity. So as you can see here, this is the femur. There's a hollow center to the bone. And inside of there is going to be yellow bone marrow. Well, what they're going to do is they're going to drill into it in order to provide an anchor point, which they're then going to insert what's called a guiding block. And this block is going to make it so that when the surgeon starts to manually put in the saw blade, that it's going to be guided to only cut the correct amount and in the correct direction. You see, when they're resurfacing the joint, they're only going to be cutting around 7 to 10 millimeters of bone. So, I mean, it's significant, but it's not nearly as significant, again, as though you were just taking entire chunks of bone. But these guidance blocks are going to ensure that they're coming at the right angle and they're getting the right amount every single time. But it's still relying on the surgeon to hold the saw blade and manually do all of this. Now, the other option is to do, again, robotic assistance. Now, if they do robotic assistance, they're actually going to insert into the tibia 2 different guidance sensors, and then in the femur, another 2 guidance sensors. So you can kind of picture there's just like these sensors coming off of the bones that they have drilled into the actual bones. And what they're doing is they are relaying positional information for the femur as well as the tibia, because during the procedure, they're going to actually be moving the knee through a range of motion to make sure that, especially once they get the prosthesis in place, that you're tracking right. Like, you don't want to rebuild the knee and then it's scawampus. You know, that's my anatomical term. And so what they'll do is they use these sensors to help guide them, but it also helps guide the robotic cutting equipment. So they will drill those and put those guidance sensors in there. And then what they're going to do is start actually digitally measuring. So the surgeon will actually able to, using a point system, actually analyze the topography, the surface of the bone itself, and relay that to the computer to provide a digital image of the surface of the bone. And it's going to use this in conjunction with the CT scan that was performed preoperatively. And what will happen is now the computer has an understanding of where the bone is and whether or not it's been cut. So then the surgeon will actually bring the blade over, and it's on a robotic arm, and so they're not holding it, but they are in control of a trigger and actually causing the saw blade to go. And what they'll do is they will then start resurfacing. And what they'll do is they will, say for the femur, they're going to make 5 different cuts, completely cutting off all of the articular surface you're seeing here. At least that's what they would do in a total knee arthroplasty. So they'll make 5 different cuts, completely removing, these are called condyles. For the tibia, they're actually going to make 1 cut that's going to just take off that entire top aspect and the 2 condyles of the tibia. And then for the patella, they will also remove this articular surface. Again, that's also controversial. It doesn't happen in every single knee arthroplasty, but that is another option. And so it's all robotically assisted. Now, what's super cool about this, though, is that there's also going to be like digital boundaries within the computer system that ensures that the surgeon doesn't go too far. Because look, over here, this right here is called the medial collateral ligament, or the MCL. Then on this side, you have the LCL, or the lateral collateral ligament. You don't want, when you're resurfacing this, to go too far and cut a ligament that you didn't want to cut. So what will happen is there's these digital boundaries that will prevent, let's say the surgeon accidentally goes too far. As soon as it goes too far and goes beyond the boundary, the saw blade shuts off and they won't cut anything that they don't want to, including blood vessels and other nerves. So really, really interesting ability right there. So again, it comes down to, and this is really just comes down to the surgical team and the institution, whether or not they're going to do this manually or they are going to do it robotically. Now, interestingly, in terms of recovery, in medium and long-term recovery outcomes, there doesn't seem to be a big difference on whether the patient received a manual arthroplasty or a robotic assisted arthroplasty, meaning 10, 15 years down the road, people are the exact same no matter how it was performed. The difference though does show up in the short term. They do see that recovery times and pain possibly is going to be diminished when it's done robotically, but again, this also will depend on your surgical team. So now that they've done all the resurfacing, they can finally start attaching the prostheses. So the prostheses are typically going to be made out of a titanium alloy, and what they're going to do is, whether it was robotic or manual, they will drill into the medullary cavity, and that will allow an anchor point to kind of like place it in. So if I kind of turn this to the side, they could slide it in like so, and it'll plug into the drilled hole. But they're not just gonna like slide it in and leave it. Instead, what they're gonna use is a quick drying bone cement that will attach the prosthesis to the actual bone tissue itself. And this is one of the benefits of using a tourniquet, is that with the lack of blood, this whole area is more dry, and it does seem as though the bone cement will attach better, and so you're less likely to have complications down the line. So again, kind of tossing that back and forth. But they will attach the prosthesis to both sides and possibly to the patella, the surface of the patella, if they did decide to resurface it. And then remember, if you recall me just saying a moment ago, there's not going to be any menisci, so instead they will insert a piece of plastic, of polyethylene, that will act as the new menisci and cushion between the new titanium surfaces of the femur and the tibia. And so once they've done this, they have everything done, they're now going to make sure that everything's tracking properly. So they'll start bringing the knee into different ranges of motion, and they're going to actually be analyzing the varus and the valgus aspects of the knee. So basically, is it bow-legged or is it more knock-kneed? They're going to try to get that range of motion and tracking as even as possible. And if it's robotic assisted, they can actually move, as they're moving the knee back and forth, they can see the exact degrees of range of motion that is occurring in real time, and they're going to get that knee to where they want it. When that's all done, it's time to stitch everything back up. So they're going to start putting everything back into place. So if you recall, again, this was actually shifted more laterally, like the patella was lateral, so they can reflect that back. They can actually stitch this area back here. They're also going to be doing pain injections all around the joint, because this, to probably no one's surprise, this is an extremely painful recovery because the amount of trauma that you've done to the area. But they'll do the pain injections. They will then put the skin back and the integument, and they will do multiple levels of suturing to kind of get everything back together. And then essentially the surgery is over. Now the recovery process is extensive, again, to absolutely no surprise. But in fact, it starts essentially immediately. So as soon as the patient is back in their hospital room and their anesthesia has worn off, this is where they're gonna have to start rehabbing this immediately. So they're gonna have to go through, they're gonna have to walk up, be able to go up and down stairs. They're gonna have to demonstrate the ability to walk. And then once they eventually do get home after a few days, maybe a week in the hospital, they are then going to have to be part of a multi-week long physical therapy regimen. I mean, it could take as long as 6 weeks to make sure that they are tracking properly. Because here's the problem. If you don't do the proper rehabilitation with the knee, right, you don't go through the right movement, the amount of trauma that has just happened to this area is obscene, to the point where there's going to be significant scar tissue formation. And if you don't move, that scar tissue is going to lock down. And when it locks down and then you try to move, it's going to be too restrictive. So you have to move despite not wanting to throughout the rehabilitative process to ensure not minimal scar formation, but proper scar formation, that it's happening in the right places to allow proper range of motion. Because the last thing you want is to get a knee replacement, not go through the proper rehabilitation, and then all of a sudden now you're just locked into this position and there's nowhere to go from there. So you gotta make sure to go through with your physical therapy. Now, when it comes to complications, there's a lot of factors that go into it. We've talked about a tourniquet and whether or not you use it and potential complications from either side. There's potential complications on whether it was a manual arthroplasty or a robotic, right? If it was a manual and say the surgeon went too far, that creates some significant complications. But the most common complications, whether it's robotic, assisted, it doesn't matter, is just improper placement, or maybe the prosthesis is coming loose over time. And if that happens, that's gonna create tracking issues, that's gonna create lots of pain, and you have just a brand new problem. The other thing is, this is one of those very unpredictable procedures in terms of, like, if you talk to anybody who's got this, or say like you talk to two people who's gotten a knee replacement, they can give you wildly different accounts, right? One can say this is the best thing they've ever done. They should have done it sooner. They feel brand new. They can play with their grandkids. Everything's great. And then the other person is like, I'm in worse pain. I'm worse off than I was. And then you're going to have everywhere in between. And there's no real way to know exactly how this is going to go. I mean, these procedures are meticulous. The surgeons are fantastic in what they do. But this is and I say this term appropriately and meaningfully, this is a violent procedure. What they're doing, they're using mallets, they're drilling into bone. Orthopedic surgery, for those of you who've never observed it, is a very intense type of surgery. And it comes with a lot of risks. And the body is not meant to, be shaved off, the bones, and have resurfaced and put with titanium and plastic and all these types of things. And so there are significant complications, which again goes back, or potential complications, which again goes back to why they prefer you to be older in age. Because if say it doesn't work out, I'm not saying we want to be immobile when you're 75, but it's better in a way to be immobile and in pain in 75 than at 35. So again, it's one of those toss-ups. So you just want to be very careful with if you're actually thinking of having a knee arthroplasty, these are all conversations you want to have with your surgical team. You want to make sure you have a really high quality surgical team. You're discussing all of this with them so you're aware of all of the potential risks and outcomes and everything that comes in between. But it is possible that, I've seen people say this is the best thing they've ever done. They feel brand new, everything's fine, they're in the garden, they're on their knees, and everything's great. So, you just want to make sure that you do your due diligence when it comes to this procedure. Thanks for watching, everybody. I really hope you enjoyed today's video. Personally, I'm having a blast doing these what to expect. They're not really instructional, but kind of like step-by-step understandings of surgical procedures. And trust me, I still left out plenty. But if you knew every single detail, you'd essentially be training to be a surgeon. But I really hope you're enjoying these videos. Be sure to let us know in the comments if you enjoy these or any other types of videos. Jonathan and I are always interested in seeing what you have to say. But be sure to click the link in the description below. Go to Yoga Body Teachers College and get your free report on how to choose a yoga teacher training program. As always, be sure to like, comment, subscribe if you haven't. I don't know why you haven't subscribed to us. If you've made it this far, you should be subscribed by now. But thanks again, and I'll see you in the next video.